Hello, my name is Pierre Cedric Crouch. I use a pronoun he and him, and I'm the Director of Nursing at Magnet over at Strut. I'm here to talk to you today about the CDC PrEP guidelines and also apply them to a community-based clinic. First off, just a disclosure, the San Francisco AIDS Foundation does receive funding from Gilead. I personally don't receive any funding from Gilead, but our organization does. So we're going to review the CDC guidelines, and then I'm also going to adjust the guidelines to show you what we do in our clinic. A couple of abbreviations you're going to see in the presentation. You'll see PrEP. We've all seen that one. That's for pre-exposure prophylaxis. You also will see NPEP. That's for non-occupational post-exposure prophylaxis. You'll see MSM for men who have sex with men. You'll see MSW for men who have sex with women. You'll have WSM for women who have sex with men. You'll have IDU for injection drug use, and STI for sexually transmitted infections. Just a little note about guidelines. Guidelines are great. They're developed with evidence-based research and a combination of professional recommendations, and they really help us all practice to the highest level that we possibly can, and also sort of standardize the care across different disciplines and different professions. The problem is that not all these guidelines are always easily applied to all different settings. They kind of need to be tailored a little bit. And also their development can lag behind in late-breaking new research. So I'm not saying that any of these guidelines are bad. They're very important. We use them every day, but we've learned a lot since these guidelines have come out, and we've adjusted them to our clinic. Now the guidelines I'll be referring to will be the ones published from the CDC in 2014 that are available here on this link. In our clinic, it's called Strut. It's a Center for Health and Wellness, and we provide services for gay, bi, queer, and trans men. And the organization opened up in January of 2015. And we're actually made up of a bunch of different groups that have been long existing in San Francisco. There's Magnet, which provides sexual health services. There's the Stonewall Project, which provides mental health and substance use services. And we also have various community engagement programs that target different groups who are at risk for HIV or groups that are actually already HIV infected. And for PrEP, we'll be just talking about one drug, the only one that's actually approved for PrEP, which is called Truvada, or emtricitibine tenofovir. It's the only one that's actually currently approved. There are new ones coming down the pipelines, but these guidelines don't apply to those. The PrEP indications. So the CDC recommends that for men who have sex with men, that any male who's had sexual partners in the last 6 months who's not in a monogamous relationship with an HIV-negative man, who might have had condomless anal sex within the last 6 months, or an STI diagnosed in the last 6 months, or who has an ongoing sexual partner who is HIV positive, be offered PrEP. Now for men who have sex with women or women who have sex with men, it's anyone who's actually has a partner who's not in a monogamous relationship with an HIV-negative partner and who has infrequent uses of condoms or might have a sexual relationship with someone who is HIV positive. So basically if they have to have a risk for HIV somewhere. And also for injection drug users, it's any injection drug use that was not prescribed and with a combination of sharing of needles with another partner, or anyone who's on methadone, buprenorphine, Suboxone treatment in the past 6 months, or they might have a risk of sexual acquisition. Within that case, they would fall into one of the other categories. So a lot of those are actually a little bit confusing. There's a lot of different little categories you have to fit people in. At Magnet, we really basically get down to it. Does the person have a risk of HIV? That's our main condition. But a lot of people want a little more detail, like what does that really mean? And so for us, we offer PrEP to anyone who's had 1 episode of condomless sex in the last year, or if they have an HIV positive partner. Though with more recent data, we actually are finding out that can be a very low risk if the partner is undetectable, or if anyone's ever shared a needle. Though needle exchange actually works much better at preventing HIV. So if someone actually only shares needles, that's their only risk for HIV, we give them a clean needle. It helps protect also against hepatitis C. If they have a risk for sexual acquisition, we also would put them on PrEP. But if that's their only risk, we would actually prefer that they just use clean needles. And we also put people on who are low risk. So these are people who have consistent condom use, or they might have a future risk. So these are people who are not doing anything that's considered risky today, but they might be doing something risky in the future. And so we just kind of pre-plan and work with them to make sure that they stay protected. Now the clinical evaluation and counseling. The CDC recommends that you get a negative HIV antibody test within the last 7 days, and also that you assess for signs of acute HIV infection. These include fatigue, fever, myalgia, rashes, pharyngitis, adenopathy. And for people who actually might have had a recent exposure to HIV, they should be offered PrEP. They also need to have an eGFR greater than 60, and to do hepatitis B and hepatitis C serologies as well. Hepatitis C is not contraindicated for PrEP. They just do it as part of a routine sort of panel just to see if they actually have Hep C. If someone does have Hep C, you can prescribe them and put them on PrEP without changing anything. If they have hepatitis B, they would actually need to ensure that they're actually getting their hepatitis B treated accordingly, and they can do the two at the same time. They just need a little extra medical evaluation to treat their Hep B alongside receiving PrEP. And then also all clients should receive PrEP and adherence counseling too as well. Now at Magnet, we do pretty much the same thing as maybe just a little bit more. We do an HIV antibody test within 7 days, and we also assess for acute HIV infection. We also have the benefit that we have access to an HIV RNA test, which helps narrow the window of exposure for HIV. And we also do a renal and metabolic panel on all of our clients. We do hepatitis B antigen and Hep C antibody testing, and we do a significant amount of PrEP and adherence counseling. And we do gonorrhea, chlamydia, and syphilis testing, as well as a detailed benefits navigation. Now, starting people up on same day is possible. There's enough testing out there, access to testing to actually provide people PrEP on that same day. So we leverage point of care testing. We do HIV tests and metabolic tests to actually get these test results while the client's actually in the room. We know that long delays just end up frustrating clients and prolongs their risk of HIV. So getting people on as soon as possible is very important. So you want to access all the different services you have so that you can actually make a clinical decision to actually initiate someone that same day. Now, why would we do this? What evidence do we have? So we know from IPREX-Olay, they actually did a screening for acute viral syndrome. So this was actually just a questionnaire that they sort of asked. And of the people they all met to put onto PrEP, about 30 of them had tested or had some kind of syndrome that actually put up a red flag where they actually delayed the initiation of their PrEP. And of those 30, only 2 of them actually had HIV infection, and 28 of them were actually HIV negative. That did cause 25 people to delay starting onto PrEP, and 3 people actually didn't start up on PrEP at all from it. But as you can see here, a simple screening, there was no one who was actually HIV positive who didn't present with symptoms who got started on PrEP. So this was a very useful tool to show that just asking questions about acute viral syndrome can actually help screen out people who might have HIV so that you can start the majority of people on the same day and only defer PrEP for a select few. Now, when you're doing kidney function testing, the main test that people use is creatinine. It's the most common one that's most widely available. But there are a lot of different things that actually cause that test to be falsely elevated. Things like exercise, dehydration, people might be on ibuprofen or creatine supplements, can all cause this number to actually go up. So whenever you're doing kidney function testing, it's always very important to repeat those tests and also use alternative tests that are out there, things like cystatin C, to help give you a clearer picture as to what's going on. You don't want to not start someone on PrEP just because they have a high creatinine that has nothing to do with their kidney function at all. Now, as far as PrEP counseling, in our clinic, we start off with 3 lead questions. We ask, what have you heard about PrEP? And that helps us figure out all the different urban legends that people have around PrEP and help kind of correct those. We also ask, what do you want PrEP to do for you? And this is a great question. You really get to find out what people want to get out of it, how they want to use it, and it really helps figure out what they want to do. And you can ensure that PrEP will be able to do that, or maybe it won't be able to do that. But you want to get that goal in mind. And then we also develop a sexual health plan by asking, what have they heard about PrEP and condoms? And we really want to just get at, what does their relationship with condoms look like? Do they love them? Do they hate them? Is it easy for them to use? And how is that going to look like when they actually start up on PrEP? And the idea is you come up with a client-centered sexual health plan that they develop with your help. Now, as far as an adherence plan, we know this is one of the most important things to talk about. If you take your pill, it's going to work. If you don't take it, it's actually not going to do anything. So we talk about when the client's going to first take their pill. We get down to a date and time and when they walk out of the clinic, when they're actually going to take that first pill. And then we talk about how to handle missed doses. If they skip a dose, they miss for 7 days, how to handle these sort of gaps, when to restart and what to do. And also if they actually are dealing with any kind of stigma issues. Is it easy for them to take the pill at home? Do they live with their parents where they actually can't take it? Or do they have a partner who can't know that they're doing it? So we actually kind of come up with a plan to kind of make sure that there's no stigma in their life or how to work around all the different stigmas. PrEP navigation, very important. It's probably the most important thing of any PrEP program, especially if you're not in a single payer system. For us, we have an entire PrEP team that actually does everything for the client. They became trained notaries and insurance enrollment counselors, so they're able to actually get all the documents signed and filled out for the clients. The majority of the time, the client just signs a form and they don't actually have to fill out anything, which is really great. We know that filling out forms is a huge barrier to accessing care, so whatever you can do to make it easier for them to look into those different options to get your benefits navigation team to provide as much service as they possibly can. Now our follow-up, for the CDC, they actually recommend an HIV antibody test every 3 months, pregnancy test if it's needed, and adherence and PrEP counseling, as well as side effect monitoring. And they also recommend that every 6 months you'll do a renal function test, and also a test for gonorrhea, chlamydia, and syphilis. At Magnet, we do a little bit different. Because we start them up right away, we do a phone call in 3 days to make sure they didn't have any issues accessing their pills at the pharmacy or any insurance issues, and also just to do an initial side effect check to see how they're doing. We'll see them again after a month, and then we'll see them every 3 months after that. And our testing for every a routine panel where we do HIV antibody test. We're also fortunate that we have access to a pooled RNA test at every visit. We do gonorrhea, chlamydia, and syphilis testing, pregnancy testing if needed, adherence and PrEP counseling, monitor the side effects, and check on the renal function, and also do an ongoing insurance and benefits check. We always want to make sure that people are not going to have any lapses in insurance. So if they have anything planning that's coming up that we can kind of plan out ahead of time and make sure that they're not going to have a gap in their insurance, we like to know about that so that if you know you're going to lose your job in a month, I want to make sure I have a plan in place so that when that time comes, you actually will be able to continue to access PrEP. And then once a year, we do Hep C antibody testing. Now, the reason why we actually do more frequent STI testing than the CDC guidelines has to do with just the fact that you're actually offering PrEP to very highly sexually active people. They're going to be getting infections. And you can see here, this is something that Stephanie Cohen had presented in 2016 about the frequency of STI testing. And what she did here, she compared the every 6-month model that's recommended by the CDC guidelines and assessing it to see how many infections would be missed if you tested every 6 months instead of doing every 3 months. And you can see here on this slide, if you test every 6 months, you're going to get delayed diagnosis of every infection. Anywhere from 20 to 40% of them will be delayed infections. And we know that the longer the delay in the infection, the more of a chance they actually have to passing it forward. And so this sort of argues that actually you want to do frequent testing. You know, we do every 3 months in the clinic, and we also do it at that month 1 visit. And even at month 1, we find a substantial amount of infections. And these are people who were just tested a month ago. You might have some clients who need to get tested every month depending on their risk factors. And so really you want to tailor this to the client and also just encourage more frequent testing and not wait every 6 months to test somebody. And that's all you have to do. And just remember, the guidelines are useful, but you want to make them yours. Even our guidelines might not apply to your community and your clinic. So be sure to tailor them to what you end up needing to do. And so thank you very much for your time. If you have any questions, feel free to reach out to me here. Thank you.